All right, so with that, welcome everyone to what is the first session of the relaunch of the clinical rounds or IPAC clinical rounds series hosted by IPAC-CSO chapter. So glad to see the turnout we have today. Judging by the registration info, it looks like we have really folks from all across Ontario with us today. I'm going to quickly throw a poll up for, if you haven't already seen that, for folks to just put in where they're coming from, what sector they work in, how long they've worked in IPAC, and their educational background. And I see some folks are responding to that, so we'll give that a few more minutes and then share the slides with everyone. Just to give a little bit of background about what the point of this session is and how it came to be. So this is a program that IPAC-CSO had started with Public Health Ontario about a year and a half ago as a bit of an acute care COP. And the idea was really focusing on acute care, clinical scenarios, and it was offered for both CSO and SWO. And then as we looked at saying, all right, well, what's the natural progression for this? We really want to look at a few areas to have some growth. So one of those areas was, of course, we wanted to look beyond just CSO and SWO, and we want to make this an opportunity to really reach out for ICPs across Ontario. We want to get beyond just acute care as a sector, because all of our other sectors, our long-term care, our public health, our primary community care, all of these other sectors certainly have a benefit for understanding clinical, complex clinical cases. And we wanted the ability to record and make these available for future sessions for anyone to be able to come and watch previous educational opportunities anytime they wanted. And so this is the official relaunching of this program. We're hoping for the initial cadence, as we're getting our legs back under us, to do this as a quarterly offering and hopefully increase the cadence as we get a little bit more comfortable with the program. The idea really is that this is an opportunity for ICPs from any sector, from anywhere in the province, to really showcase complex cases, case series, outbreak investigations, or any really clinical focused scenarios. And so if you have a setting or a scenario that you're interested in presenting on, I will throw my email into the chat. Feel free to email if you're interested in presenting. Our team at CSO will work with you to create a presentation, format the presentation. We'll take care of all of the digital side of the house, and really give it an opportunity for you to come on out and present something unique that's happening in your setting. And you get 2 IPUs instead of 1 for presenting. So anyone looking to maintain their CIC, it's a great way to rack up those IPUs. So I'll throw my email into the chat there. If anyone's got any questions or is interested in participating, feel free to reach out. In the interest of time, it looks like we have most of our participants have responded to this poll. So I am going to go ahead and end the poll, and we'll share the results here. So looking at where folks are coming from, the vast majority are coming from acute care, 61%, but great to see we have some long-term care representatives, some public health representatives, some government folks, primary care, and the other. For anyone who said other, feel free to throw what where your sector is into the chat. I'd love to know where you're coming from. Certainly, I apologize for having missed you on the poll. In terms of how long you've been working in IPAC, so we have some folks who are under a year, and then some 1 to 5s, and then a couple folks who are into our higher demographics, including some over 20s. Outstanding, great to see this mix across the board. The idea with really these sessions isn't to be novice focused or experienced focused. It's to try to be accessible for everyone, so that we have both learnings from a novice ICP's perspective and still some good clinical pearls of wisdom to take away for our more experienced ICPs. Most are or do have a CIC certification, some do not. That's great for anyone who is looking to get IPUs for maintenance of that CIC. At the end of this session, and I will remind you of this, there will be an exit survey that pops up. One of the questions on that exit survey is, if you are requiring IPUs, please input your email here. Please pay attention to that. If you are requiring an IPUs, that's going to be our way of tracking who actually attended the session versus those who just registered. And then lovely looking at where folks are coming from. It is fantastic to see almost every Ontario chapter is represented here. This is something that, you know, the group, the CSO committee that was planning this was super excited to see from the registration side that we have things more than just CSO, or folks more than just CSO coming out. It's great to see folks from across the province. And this may be a first for IPAC Canada local chapter hosted events, that we have this much breadth. Certainly a first for our chapter here in CSO. And then lastly, the really interesting one is your educational background. So as we're not surprised with in IPAC is a lot of folks do come into IPAC from a nursing background. But one of the things that is really interesting in infection control is that more than just about any other career in healthcare is the breadth of backgrounds and experience of folks coming into the profession. And as we look at that really changing through COVID, what our role as ICPs are, stepping away from more of the administrative tasks of, I sit there and watch you wash your hands, and I'll occasionally tell you to put someone in or take someone out of isolation. You know, we're really driving into that more clinical specialist role of being the experts in understanding how diseases are transmitted in a healthcare setting. And so what I hope we could take away from these sessions is really that ability for anyone with that background or any kind of clinical background to come together and look at a different way of looking at clinical scenarios and clinical cases. All right, so with that introduction as to who we are and where we are, I think our participant role is starting to level out. I'll do a quick introduction to our speaker today, Trish Beckett, registered nurse and infection control practitioner at St. Joseph's Healthcare Hamilton. Trish has an absolutely wealth of background and experience in healthcare. I'll actually turn it over to Trish to introduce herself and talk a little bit about or dive into our session today on bacteremia surveillance. So Trish, over to you. And just as a reminder, questions will be at the end. So if you have any questions, you can throw them in the chat as we go, but we'll be tackling them at the end. Although there will be a few opportunities through the talk for some engagement as Trish goes along. Trish, over to you.
Thanks, Kevin. Hi, everyone. My name's Trish Beckett, and as Kevin said, I'm a registered nurse and infection preventionist here at St. Joseph's Healthcare in Hamilton. I have spent my whole career at St. Joe's, which I think is a bit of a unique phenomena these days. And I do have quite a diverse background. So I started my career in nephrology. I went to psychiatry, critical care, medicine, and now in infection control. So I started in infection control in 2012. And it was kind of a unique situation. I developed a severe hand infection and I wasn't able to work on the floor. So I was given the opportunity to work with the IPAC team here at St. Joe's, and I guess I just caught the bug. And so I've been here ever since. So 11 years later. So our objectives today, and what I'm hoping to instill some knowledge, is to provide you with a bit of an overview of the ICP's role in BSI surveillance, the importance of that surveillance, how to do blood cultures, how to interpret those results. We'll also be reviewing some of the best practice guidelines for line insertion and line maintenance. And then I will present to you some cases and why and how all of this kind of came to be for me. So At the time, this was in 2021, I was the ICP covering GI surgical floor, and we had 2 VRE bacteremias within a month's time. So that, and neither one of these cases were related, and our facility has a very, very low rate of BSIs, VRE BSIs. So this was really out of the ordinary. So it prompted me and my team, or us, to do a case review and determine where these patients contracted this VRE bacteremia. And interesting to note that neither one of the patients had VRE colonizations prior to their bacteremia, and we didn't have a high burden of VRE on this particular unit. So surveillance is, according to IPAC, is the systematic ongoing collection and collation of and analyzing of data with timely dissemination of information to those who require it in order to take action. Active surveillance for hospital-acquired infections is defined as the direct and vigorous search for information on the occurrence of HAIs in order to detect the change or trend in the incident rates. So in my learning and reviewing of these cases, I learned that surveillance goes beyond just collecting data. It also involves analyzing the data, reviewing practice, and then communicating all of that information back to the key stakeholders so that we can improve our healthcare outcomes. So for me, these 2 VRE BSIs were my trigger to do the investigation. So these are the elements of surveillance. So detect and monitor, identifying risk factors, evaluate preventative interventions, and then provide information, inform, educate, and reinforce practice. So these are what I used to assist me in investigating these healthcare-associated infections, and then we're to use this to improve our patient outcome. So we'll use this framework a little bit later when we're reviewing our cases. So it's important to understand that you use a standardized definition for healthcare-associated infections. And that's so that you're comparing apples to apples. And we need to know that our data is correct and consistent. So a healthcare-associated infection or a nosocomial infection are infections that are acquired 48 hours after admission to the healthcare facility. And as per the National Healthcare Safety Network, 70% of all healthcare-associated infections are preventable. So that's a huge number. And our job as infection preventionists are to keep our patients safe. So an effective surveillance system needs to be in place to reduce the frequency of healthcare-associated infections, including bacteremias. So NHSN defines a laboratory-confirmed bloodstream infection as one of these 2, meeting these 2 criteria. So a recognized pathogen from one or more blood culture and an organism cultured from blood that is not related to an infection at another site, or fever, chills, hypertension, a positive lab result not related to another site, or the same common commensal organisms cultured in 2 or more blood cultures drawn on separate occasions. So this just kind of gives us an idea of our definition and what we're going to be using. So why are we concerned about bloodstream infections? So a prompt identification and treatment is the most important predictor of outcome for these patients. So there are the consequences of bloodstream infections are increased mortality, increased hospital costs, increased length of stay, and definitely it's really hard to define the impact on patients and families when they get these significant bloodstream infections. So blood cultures are important diagnostic tools that we use to identify pathogens that are responsible for the patient's infection. So a physician will order blood cultures when a patient has signs and symptoms of infection. So it's very important to obtain the blood cultures before antibiotics are given so that they don't screw the data. And to prevent contamination of the specimen, the practitioner must be knowledgeable about how to collect the specimen and to make sure that they're performing hand hygiene to reduce that risk of contamination. A set of blood cultures consists of 2 bottles, an aerobic and anaerobic bottle. Each will contain 20 to 30 mils of blood per bottle. And 2 sets of blood cultures are usually drawn at one time, usually from 2 separate venipuncture sites, or it could be selected from or drawn from a central line lumen. Usually we get results within 24 and 72 hours. So the first results, or the preliminary results is a gram stain. Now, I do not have a microbiology background, so I apologize for dumbing this down significantly for my MLT friends. But I just don't have the words or the knowledge to explain this very well. But anyways, so a gram stain will be what you will initially receive, and this identifies what the cell looks like, the organisms look like, and then whether or not they're a gram-positive or a gram-negative organism. So this is clinically important to the clinician to help them to guide them to selecting the appropriate antibiotics until the final result is back. So time to positivity. So in the microbiology lab, when the instrument detects the growth of the organism, it measures the time to positivity. So they put the culture in the machine, the medium grows, and when the machine detects the organism, that is your time to positivity. So this is very important information for the clinician. So you can kind of assume that if the time to positivity is short, then there is going to be lots of organism that is present. But conversely, if your time to positivity is long, that there is a low burden of organism. Also, time to positivity also helps to determine whether or not a central line is associated with the bloodstream infection. So if the time to positivity of the sample taken through the central venous line is at least 2 hours shorter than the sample from the peripheral vein, and the microbe and the susceptibilities are the same, then you can safely assume that this might be a catheter-related bacteremia. So blood culture contamination is a significant problem. Lots of microbiology labs have this issue, and virtually all of the contamination occurs during specimen collection. So this is why it's really important that the practitioner knows how to draw blood culture properly, and of course is doing their hand hygiene appropriately to prevent this contamination. So poor technique and insufficient skin disinfection is usually one of the risks, or increases the risk of contamination. So the source of contamination is usually the patient's skin, so you don't clean the site appropriately, or the hub or the cannula on the lumen is not cleaned appropriately. So it's very, very important. So 2 very important things is when you're cleaning the site, to make sure that you're using chlorhexidine and making sure you allow it to dry. And if you're taking it from a lumen, that you're scrubbing the hub well. The other important factor is to disinfect the blood culture bottle septum. That cap is not sterile, it's just a cap. So you need to clean that before the blood specimen collection is done. So this diagram kind of shows some areas of contamination that can happen with an intravenous catheter. So the number 1 is the first area is the lumen at the insertion site. So it can be contaminated with the patient's own skin flora or healthcare workers' hands, or inappropriate or improper disinfection at the time of insertion or line maintenance. The second area is the contaminated catheter hub. So again, the patient's own flora can contaminate that hub, or healthcare workers' hands are not scrubbing the hub appropriately when connecting the tubing. And then the third is contaminated infusion. So like your medication, your fluid is contaminated and you're injecting it into the patient. So what are the consequences of contamination? So unfortunately, patients could then be exposed to antibiotics, unnecessary antibiotics, which could cause many downstream effects, including allergic reaction to the medication, or as we all know, C. diff infections can occur from antibiotic use. It also, if the lines are contaminated, it could cause the practitioner to remove IV catheters or other devices. It increases your length of stay, it increases the hospital costs, and then, of course, the impact on patients and families. So this is a table that I've kind of created on my own. I think it makes some sense. So use it with caution. So a positive blood culture. So this is how to interpret blood cultures. So a positive blood culture with a known pathogen has generally an overall high positivity predictive value of an infection. So if you have a Staph aureus or gram-positive cocci in clusters, the most likely this is a true infection. So a contaminated blood culture is generally defined as one set out of multiple sets being positive for a commensal flora. So that's your maybe is your coag-negative staph, your staph epi. Those are skin floras that could potentially be a contaminated in your blood culture. So your time to positivity, if it's greater than 72 hours, there's a high chance that this is a contaminant. How the organism looks is also beneficial to the clinician to help provide to kind of guide them in the treatment. And then whether it's aerobic or anaerobic, it has limited value in the initial treatment, in the early interventions and early treatment, but it does help the clinician when we know what the organism is. The other things that we need to take into consideration when you're interpreting blood cultures is, why are these blood cultures done? Where were they done? Were they peripheral? Were they central line? Does your patient have signs and symptoms of an infection? Do they have any risk factors for a bloodstream infection? Do they have hardware? Do they have central line a central line inserted, a Foley catheter inserted? Is your patient immunocompromised? So this is kind of a quick little sheet that I found a little bit helpful. So next we're going to talk a little bit about central line care, central line insertion bundles, just to kind of round out the blood culture topic. So the central line insertion bundle is, of course, hand hygiene. So, and also a maximal full body sterile drape, and also PPE worn by the practitioner that's inserting the line. So that includes a cap, a mask, sterile gown, and sterile gloves. Making sure that you use 2% chlorhexidine with 70% isopropyl alcohol as your skin prep, using friction when applying the disinfectant, and making sure you're allowing it to dry. For a central line, it's important to pick the appropriate site. So the subclavian vein is your least likely to become contaminated, then your internal jugular, and then your increased risk in a femoral vein. The use of an ultrasound guidance for insertion improves risk of trauma and to making sure that they put the line in the appropriate place. Single kits or carts where all the supplies are together in one place is also helpful. and the skill of the practitioner. So making sure that the person who's putting in the line has the education and knowledge and training that's initial and ongoing, so that there decreases the risk of trauma to the patient. And then, of course, the direct observation of the line insertion. So having someone watch you put the line in, so they have a different view. They can see if you break sterile technique. And then documentation of that insertion and compliance also is important. So central line maintenance bundle. So making sure that you review all central lines or IVs in general, or all lines in general. And if it's necessary, keep it in. If it's not, then take it out. Monitoring for ongoing signs and symptoms of an infection, so infiltration, phlebitis, leaking. Making sure that you're using aseptic technique when you're accessing that site or accessing the line. So making sure that you're doing that moment 2 hand hygiene before you give that medication, before you do that dressing change, and you're scrubbing the hub when you're accessing the lumen. IV catheter care, making sure that you're using good hand hygiene and a clean or sterile technique when doing the dressing change, and making sure that you use the appropriate kind of dressing. So ideally, it would be a sterile, transparent, semi-permeable polyurethane see-through dressing covering the site. And then that is changed every 7 days or as needed when it's not intact. And then making sure that you're using the appropriate disinfectant to the skin, so your chlorhexidine, and making sure that it's dries. So catheter management. So there's lots of research about line management. So dedicating a lumen for TPN. So because TPN has lots of sugar, bacteria and microorganisms love to grow in that sugary environment. So making sure that the lumen is dedicated for that, for TPN, nutrition. If you have an unused line or lumen, that you're using a sterile normal saline flush, and that you're putting a sterile dead end cap on the end of that lumen, and that's every 24 hours or as needed. That you're securing your intravenous with some sort of securement device, so that the catheter doesn't move. Tubing changes as per your hospital policy. So there's many different, intermittent, continuous infusion, blood tubing, TPN tubing. The newest recommendation is to make sure that you're also changing the extension tubing with your line changes. Labeling of your IV tubing and your dressings with the date and the time is important to prevent long-term use of that line. The antibiotic locking solutions do play a limited role at this point. There is still ongoing research whether those locking devices have an impact. And then, of course, documentation of the line is always important. So our cases. So the 2 cases that I don't know how much detail to give or not give, but so the first case is an 80-year-old female who presented to our emergency department from long-term care with delirium and lower abdominal pain. She had multiple investigations when she arrived to our facility. She presented with kind of a SIRS-like presentation, so a fever, tachycardic, tachypnic. She had an elevated white blood cell count. Her lactate was elevated. Her original, she had blood cultures done. The original culture, the first culture was negative. The urine culture, the nitrates were positive. And she had a CT of the abdomen that showed cystitis with severe diverticulosis. So she was initially treated with amoxiclav, and then when the urine results came back, it came back as an E. coli ESBL. So she was treated with a single dose of fosfomycin. Then she went back to the long-term care home. So she didn't do well. She was back at the long-term care home for a few days and then returned back to presenting to our emergency. She was sicker, fever, tachycardic, lower blood pressure, higher white count. And her first set of blood cultures were negative, and her second set of blood cultures grew Staph hemolyticus. So just a kind of a shout out or a question to the group. Do you think this is a true infection, or do you think this could be a contaminant? So just something to think about. I think in the presence and in reviewing her chart, it was probably a contaminant. So one of two. Her urine was negative. She was treated with IV fluids, and she was given ertapenem and vancomycin because of her history of E. coli ESBL. So a Foley was inserted. She had another CAT scan, which showed she now has a new abscess formation in her abdomen. And she continued to do poorly. She had a PICC line inserted, and blood cultures were done for the PICC, and they initially were negative, but then ended up becoming positive for VRE. Her urine culture initially was Candida albicans, and then her urine cultures was Enterococcus and Candida albicans. So when the primary care physician was reviewing her chart, it was around before the result of VRE. So the original gram smear was gram-positive cocci in pairs and chains at about 15 hours. So she was started on lazinazide, and so this was significant for us. Probably difficult to say why she developed VRE bacteremia. Our second case, 72-year-old male that was admitted to hospital for a kidney transplant. So during his surgery, his bowel was nicked, and he was given a 5-day course of Pip-Taz. So he was discharged home. He was followed up in our transplant clinic, and his urine initially tested Enterococcus species, and he was treated with Cipro. And about 4 days after that, the urine resulted as a VRE. On the same day that we got the result for VRE, he went back to the OR to have his standard post-op stent removal, and he did not receive any pre-procedure prophylaxis. And then 3 days after that, he ended up with a VRE urosepsis, was treated with daptomycin. So looking back at our elements of surveillance, so detect and monitor. So it was brought to my attention, these 2 VRE positive blood cultures, they were way above our baseline and our benchmark. So I did auditing of the practices with all of the different devices. So an IV, the Foleys, the kind of care that these individuals were receiving. I also did audits of routine practice, PPE compliance, isolation on the unit, and of course, hand hygiene. And then what were the risk factors that these patients had that potentially gave them these VRE bacteremias? So significant antibiotic exposure. They were both very medically complex patients. The one patient was immunocompromised because he had just received a renal transplant. And both of them had lines and devices inserted, and the one patient went for surgery. So in reviewing the cases, one of the things that we identified that the Foley on the first case was probably initially put in appropriately, but eventually was probably left in a bit too long. The PICC line maintenance for that lady was also kind of suboptimal. And then for the second case, the antibiotic pre-procedure potentially had the patient got some daptomycin before they had their procedure, might have prevented his bacteremia. So one of the things that I ended up doing after all of this is we did lots of education with the nursing staff about line care, about CODI prevention, and we did a review with the surgical team to make sure that they were using the appropriate antimicrobials pre-procedure. So both of these cases had significant antibiotic exposures. So I think case number one was kind of difficult to define, but it was definitely a hospital-acquired bacteremia, secondary to either the catheter, the Foley catheter being in, or the abdominal abscess, or a PICC line infection because the PICC line blood culture was positive. The second case was a hospital-acquired bacteremia secondary to a UTI after his invasive procedure. So I hope that I've been able to pass on a little bit of knowledge about how I investigated these VRE bacteremias. Always remember that it's important to have a good definition, the knowledge of how to interpret your blood cultures, and make sure that you're reviewing your best practices and circling back with the healthcare team on how to improve performance, decrease the risk to our patients by decreasing the hospital-acquired infections. And that's all for me.
Thank you so much for that, Trish. There was a question in the chat from Manish. It was the first case, and for that matter, the second case, positive for VRE colonization as well, or do you guys do surveillance for VRE colonization?
Yeah, we do. They were both negative. So both of them were negative for colonizations prior to their VRE bacteremia.
Do you happen to recall did they end up converting to a colonized patient after the fact, or did this end up being as a,
we
just
weren't
as a clinical?
Yeah, we weren't able to get appropriate surveillance specimens because they were both on antibiotics. So we did test them, but they were negative, but they were both on treatment. So can't say for certain that they were negative or positive.
Or no? So then I'll turn it over to the group here. Are there any questions for Trish on anything she's presented? Feel free to come off mute or throw questions into the chat. I do see one from Erica. Were there any epilinks between these two cases or any suboptimal antibiotic practices?
So no epilinks that I could determine. They were on different ends of the unit. They were actually not in hospital at the same time. Our VRE burden on this particular unit, whenever the isolation burden was higher, so when we had lots of AROs on the unit, because it's a surgical unit, I find that the transmission occurred, but we didn't have a significant VRE burden on the unit at that time, so could not delineate any direct epilinks. I don't think I honestly didn't look at their antibiotic dosaging for their other infections to know whether or not they were suboptimal. So I don't know that.
So then in terms of Trish, in terms of kind of immediate actions when you get these two reasonably close in time VRE bacteremias, did you point prevalence to the unit or call an outbreak based on this, or how did that kind of pan out?
So we didn't call an outbreak. We did not do a point prevalence that I recall. This was a few years ago, but we did make sure that all the patients were getting their surveillance swabbing done on admission, so that we had their baselines, because in both of these cases, we did have baseline negatives prior to them being hospitalized. So it was more, we learned by, some of the practices were poor. The nursing care wasn't the greatest at times, so dressing changes and central line care wasn't very good. So probably contributed to those transmissions.
Gotcha. Okay. I see Sandy's added into the chat. Was there any typing between the two cases?
I did not do typing, no.
Okay. And then Cameron Thomas says, so both patients were on the same unit, but with no direct crossover in timeline. I think that's what you said, correct?
Yeah. Yep.
So look at cleaning of rooms and equipment. Absolutely. That shared equipment side of the house, hand hygiene side of the house.
Yeah, so we did all of those audits. We made sure practice was good. Cleaning of equipment is kind of an ongoing issue for a long time on our surgical program. Cleaning and tagging, so they do clean, but they don't necessarily tag the equipment. So that could be a factor. But again, the geographical location of both these patients were in much different areas of. So I don't think cross-contamination of equipment played a factor at this point.
So any questions from anyone else? Otherwise, I have more questions. So don't want to monopolize. And again, feel free to come off mute, throw your hand up or whatever. Not hearing anyone else. I will ask Trish. So when you approach these, because we know that surgeons, and perhaps it's just a cardiac surgeon piece, are extremely gun shy about pulling their PICC lines, or rather they're perhaps overzealous is maybe the better word of pulling the PICC lines. Patient has a fever, pull the PICC, we'll restart it later. So when you're approaching this as with your nursing background, when would you kind of look to say, all right, it's an appropriate time to pull the PICC as you're working up this? Patient has symptoms, we've drawn results, we're getting gram stains, we're getting actual organism names, we're getting resistance or our antibiogram results back. How would you kind of approach that?
So I think I think a lot of factors play into it from a patient's side, right? So I believe the initial lady, she had poor veins, so very poor access. So kind of reluctant initially to take out that PICC line because she needed the intravenous for care. And the repeat cultures, and that's part of it too, right? So you get your original blood culture, but then the physician will order repeat cultures once they're on treatment and determine whether kind of that risk benefit, is it safe to leave that line in? Is that safe? How long has that line been in? Has it been in for a month? Has it been in for a year? We try to line save as much as we can. But as we know, the longer the line stays in, the higher the risk of the biofilm and the contamination of that intravenous. So ultimately it's the physician's and of course, if the site looks bad, then we pull the line. If there's active infection at the insertion site, then those lines usually get pulled quicker. So it's a collaboration effect of the nursing, of assessment of the line and the needs of the patient.
Gotcha. All right, thank you. Any questions from anyone else for Trish?
I can breathe now.
All right. Well, one thing that I kind of see listening to this talk, and I see this all the time at our organization, and I know others have echoed this, is that lack of understanding from a lot of clinicians and frontline staff along what happens with blood tubes when they land at the lab, right? They get the gram stain and they go, fantastic. So what's the organism? And it's that I think it's quite useful for folks to understand that from the moment that gram stain comes in, that's when it's just now being plated onto agar to start growing up, and then the organism will be at least 24 hours on a good day, assuming it's a fast growing organism, before they can get it into a MALDI for ID. And so that ability for an ICP to understand what those prelim gram stain results are and what they may mean in terms of interpretation, including some of those things like time to positivity, as well as how many of those blood cultures are positive, is a great way for infection control practitioners to really be an active member of that clinical care team and help to guide our physician colleagues, our nurse practitioner colleagues, our frontline nursing colleagues into kind of understanding how to take some of that data. Trevor, please.
Yeah, actually, that has me thinking about being an active team member. How well were you received, Trish? How well were you received? How involved did you become? Was your opinion and expertise actively sought and then acted upon?
So in the initial case, I wasn't involved in the initial care of the individual. So it wasn't until we got the VRE result that we became involved in that case. And then with the second case, again, it wasn't until I got the result. Initially, so my when I was doing my initial education and presentation to the staff, I was a bit aggressive. So I kind of stepped on a few toes, made some mistakes, and but then, redefined and, kind of changed my way of how I presented the information. So I did.
Do you feel
There was
comfortable
some
sharing that, Trish?
Well, yeah, I just so the way I presented the cases to the staff, they kind of thought of it as derogatory, like they caused it, like they were the ones that got these patients sick, and which wasn't the case at all. So I had to modify my presentation and the way I approached the staff. But that was a bit of an initial jolt. It was not my intention, but did learn from that.
Okay, cool. And how well received was your guidance and recommendation after that? Like, did they involve you in those discussions?
Yeah. So it was really so once we had the information, it was actually really helpful. The nursing staff was really kind of keen of learning about VRE and VRE bacteremia, and could identify some breaches, and they were able to learn from their colleagues, not just me telling them, this is the potential, this is how the patient potentially got it. So it was very engaging conversation, and the staff responded very well in the end.
Any pearls of wisdom or practice changes that were spurred out of this?
So I think we really reinforced the remove the Foley as soon as you can. So in that first lady's case, her Foley was in for almost 2 weeks, and probably didn't need it after the first 2 or 3 days after her initial fluid resuscitation. So making sure that those Foleys are out as soon as you can get them out. A lot of nurses have the mindset that, well, a Foley catheter, there's no harm in a Foley catheter. And that's just definitely not the case. It's an invasive device, and it can cause infection. So, it's very convenient for the nurse to have a Foley catheter, but it's definitely, there needs to be very defined places and times for those devices to be in place.
Sorry, last question. Sorry, Erica.
Yep.
Did it spur any kind of like official or formal response?
Yeah. So
like a new bundle, a new prevention bundle or something like that?
Yeah. So we did CAUTI training. So that was one of our big implementations after this, was making sure the staff, we did the CAUTI prevention bundle, and it kind of stirred throughout the whole organization.
Oh, okay. Thanks, Trish.
Erica, over to yourself.
Yeah, thank you. Trish, great presentation. I was one of the people that clicked other for background. So my background is not a nurse, but when you said nurses think there's no harm in a Foley, like my eyebrows went into my hair. Like, how prevalent is that with the newer nurses? Do they think that?
I think I haven't worked on a floor in a few years, so I can't say for certain. But I think that used to be an old school message. You know, we used to keep the Foleys in for days and days and days and days, and it was very convenient for the nurse. I think there is more education out there about getting these things removed as quickly as possible. So I know at our organization, it is part of the nurse's daily activity to assess the need of those lines. So whether it be an intravenous or a Foley catheter, that is part of their daily assessment, whether or not that line is in place. So I think the old mantra is leaving, and the newer ideas are getting out there.
Jeffrey.
That was an excellent presentation, but I think you just hit the nail on the head with your current statement. It's all about we're preventing, and it's not about your current convenience, right? Yes, you know, there's processes and procedures to follow, but if you cut around the corner, then that's what's going to lead to the breakdown in infection control. So I was looking at, you know, the list of antibiotics that, you know, your two cases were going through, and you know, again, you know, we have so many physicians who are just like, yeah, don't worry, I can just throw another antibiotic on. Well, no, I mean, the whole principle, like one of our pillars is antimicrobial stewardship, right? And again, yes, it's convenient to shove in the Foley, but we increase the risk. So we really have to, as you said, get back to that education and having the proper mindset of doing things properly. You know, you know, even though it's easier to do this and do that, but then in the long term, we're looking at, you know, patient outcomes, right? It's at the end of the day, it's convenient for us, but it's the patient who's going to go and suffer through all the facts that these are the sequelae that they're going to live through. Yeah. But thank you. No, it's excellent comments and excellent presentation.
Thank you.
Marissa?
Hi. So I just had a question about the blood collection for this particular unit. Was it best practice for them to collect blood from central lines for any blood that needed collection, or would they collect blood like through venipuncture instead? Do you know?
So on for this particular unit, they do they would do like if the physician just ordered a blood culture, they would do it venipuncture. I think in these particular circumstances, the central line blood work was actually ordered. So it's not routine practice that the nurse do it from the central line. It's mostly venipuncture. But I think in these individual circumstances, the physician had requested the blood work from the PICC line.
Okay, so it's typically physician request as opposed to like getting it from the PICC as opposed to, yeah.
I think it depends on the nursing unit in our hospital. So like the surgical floor would definitely be venipuncture, whereas critical care, the nurses would know to do it from a central line as well. Okay,
all right, thanks.
Although I think that's a great, you know, it's a great point. So best practice if you're ever coaching nurses or physicians for that matter, on, all right, my patient has a PICC, where should I be drawing from? Is best practice really is a peripheral set and a set through the PICC. It's not a set through the PICC alone or a peripheral set alone or two peripherals when you have a PICC. You know, drawing one through the PICC and one as a peripheral is really quite useful for identifying, is this truly a bloodstream infection? Is this a contaminated PICC? Is it a contamination? Is it a colonized PICC? You know, that becomes a really important thing that I think a lot of physicians do miss on their order sets.
Yeah, and I ask because we're just working on central line infection or CLABSI surveillance for our 3BR oncology unit, and they just told me like 2 minutes before this meeting that they have like been noticing an increase in their like staph epidermidis through their lines. So, and they've said that they're not going to be collecting from lines unless like there's another reason for it. They're going to start doing it. Yeah. So this was like, they just told me that today. They said they'll be doing it all through venipuncture, like no lines, unless it's necessary to pull from the line, like if the patient has difficult veins or something like that. So I just was a little bit surprised to hear that as well, because typically, yeah, it's both.
I would have serious questions on that practice.
Yeah, same
And I
here.
mean, if they're finding a significant amount of staph epidermidis through the lines, maybe that's an indication that they're not following their appropriate line management and they're actually getting contaminated lines or colonized lines, right? And so they could even further go and assuming the patient is, you're not going to make a patient hemodynamically stable by doing this, is draw a set through every lumen of the line even. To figure out, is it truly a contaminated lumen or a colonized lumen, right? How long has the line been in situ? Are you looking at biofilm growth within the lumen? But yeah, I would agree that is raised some eyebrows, and I would definitely push back on that as an appropriate practice.
Yeah, I heard about it from the nurse educator and from the charge nurse today, and I was like, okay, I think I need a little bit of clarification on what's going on here, like if this is a short-term practice or what this is going to be for. So yeah, no, because I always thought it was from both as well.
Yeah, the other piece would be making sure that whoever's doing the blood work is actually like cleaning the lumen and cleaning and making sure you're cleaning the skin when you're doing and scrubbing the hub, right? So those are three things that we really reinforced after this is actually, making sure that they're doing those steps to prevent the contamination. We had an incident not too long ago with contamination with bacillus, and we couldn't figure out this. We had lots and lots of cases, and they were 99% of them were contaminants, and we couldn't figure out the source. It was bizarre. It lasted for probably almost a year, and then doesn't happen anymore. So.
Rhonda, over to yourself, please.
Hi, I'm Rhonda. I'm the IPAC lead in long-term care here in Longsu, and I just wanted to comment back when you previously mentioned about Foley catheters. We often receive new admissions from any of the hospitals, and typically the majority of the time they come with a Foley catheter, whether it's by convenience or not. Our nurses are on the ball and we get that discontinued as soon as possible. And on the rare occasion, it's had to be reinserted if they've had any indications for the need, medically.
Do you have a bladder scanner? Do you have a bladder scanner?
No, we do not.
Oh, that would be lovely, because then you take the Foley out and you scan the bladder to make sure it's, needed or not needed. So
it just seems to be they could have just went in for a fall and they come to us and they have a Foley catheter. So it seems more by convenience, majority of the time. So we get those out as soon as possible.
That's great. Great practice.
Well, that's a great opportunity.
Bad for them. Bad for them. Good for you.
Take that back, right? So acute care ICPs, work with your discharge teams, because it's impacting other sectors when we start to do bad practices in hospital. Trevor, I'll go last question to yourself, and then I'll just do a quick closing remarks, and then we'll call it a day.
That's okay. I see that we're coming up to our time, so go ahead.
All right. Well, then, in that case, first off, thank you so much, Trish, for braving the first kick at the can at relaunching this series and presenting for us. I do want to take a second to acknowledge everyone from the IPAC-CSO committee responsible for this series. So we have on the line, of course, Trish, who is on our committee, Trevor Johnson on our committee, Brandon De Silva, Boyce Marufov, who is our CSO chapter president, and I believe I did see Eva Hatzes on as well today. And so, like I said, our hope moving forward is we really want to look at ways to say, how do we get any ICP across the province who wants to talk an opportunity to present? And so if you have a case, a series, an outbreak investigation that you'd like to present on, feel free to reach out. And our role as a committee is really going to be helping to get you situated in order to present and giving you any coaching and guidance you might need. When you exit this session, you will get that pop-up for a exit survey. Please, especially if you are entering for or looking for IPUs, please complete that survey. The emails in that survey will be how we track who we need to send certificates for IPUs to. Otherwise, I will ask for the committee to please stay on after the call. And I wish everyone a great rest of your day and happy start of the respiratory season for everyone.